Hello?
Yeah, we can hear you, beta.
Okay.
And this is the last case, right?
Yes, yes. So the next case is of a 50-year-old female, known case of diabetes and hypertension. She came with a complaint of epigastric and right upper quadrant pain for about an year. She had an MRCP done on 6 January 2019 that showed a smooth narrowing in the distal CBD associated with prominence of proximal CBD and intrahepatic biliary duct dilatation. However, no filling defect was identified to suggest cholelithiasis. This MRCP was followed by an EUS done on 21st March that says CBD appears dilated of 8.1 mm, no stones seen in the CBD and no mass seen in the ampulla or periampullary region. Pancreas and pancreatic duct also appear normal. Rest of the visualized viscera also appear normal. So ERCP was advised with the impression of papillary stenosis. Her current LFTs are within normal range with a total bili of 0.26 and alkaline phosphatase of 108.
Okay, I may have shot myself. I did the US and I couldn't see a tumor. This was a patient with a dilated CBD on MRCP.
Yes, sir.
Yeah, I remember this patient.
Okay.
What were her LFTs, beta?
So total bili of 0.26 and an alkaline phosphatase of 108.
So her LFTs are normal.
Yes, LFTs are normal.
And she has abdominal pain.
Yes, she has abdominal pain.
So, this is a clearly dilated CBD with abdominal pain and a normal LFT. So, this is SOD. And the dangerous one. See, I have. This is interesting. Khalid ko zara pura sisti bana de, Khalid. Did you hear the history?
I heard a portion of it.
I can't hear you, but I think you can hear me, right? Okay.
I heard a portion of it.
Okay, let me tell you, this is an interesting one. So before we start,
Okay.
this patient was referred to us. She's got abdominal pain, normal LFTs, ultrasound showing CBD dilatation, MRCP showing CBD dilatation till the distal end, no stones. I did an EUS and I saw a dilated CBD, but no mass. She is, how old is she? 60 ki hai, kitne ki hai? I can't remember how old, but she's not. She's middle age for sure, depending on what middle age is in. So, Khalid.
Can you hear me?
Yeah, I can hear you.
Yeah. So I think.
So we have normal LFTs, but abdominal pain, with right hypochondriac pain, MRCP showing dilated CBD 8.1, EUS showing no mass and no stones. I couldn't see any.
Okay.
And again, distal dilated CBD till the distal end, but normal LFTs.
Okay. So we're suspecting papillary stenosis. That's what.
Possibly that was one of the possibilities, but I am also concerned about possible SOD.
Yeah. So
the
same
same.
thing is the problem is at the sphincter.
So sphincter is the problem, and the question was, obviously, what do we do here, because the patient is symptomatic.
Okay.
And we have one abnormality which has been confirmed by 3 modalities, and that is the dilated CBD with a intact gallbladder.
Intact gallbladder. Yes.
Yeah.
Okay. And so that would be just, can you ask the trainees and audience, if we are suspecting a sphincter of OD dysfunction, what type that would be?
What type of SOD dysfunction would this be? Pain but normal LFTs.
No, and dilated bile duct.
Yeah. Type 2.
Okay. Yeah. So in type 2, now you have to realize that SOD type 3 does not exist anymore. And I think we're having an issue with the sedation here. And
what, over sedation?
वो कह रहे हैं कि कल कर लें, patient went into apnea actually.
Oh God. Okay. Well, might as well do it tomorrow then.
Yeah, so I think may have to intubate tomorrow and then do it.
Okay, that sounds good.
Okay. So so what I was trying to say is like 3 types of SODs, and SOD type 1 easy, straightforward. Type 2, which we talked about, pain with either dilated duct or elevated enzymes. And type 3, which is mainly a pain, and we used to do a sphincter of 4D manometry for those. And but you know that the trial came, and now we think the SOD type 3 really is a type of IBS and does not exist anymore. So type 1, the treatment is really a sphincterotomy. You don't need to do any manometry. With type 2, I don't know what's Mustafa's opinion, but some people do a manometry still, others don't, and these patients also require a sphincterotomy. The only thing doing a manometry and checking the pressures would be gives you a diagnosis. But keeping in mind sphincter of 4D manometry, when you do it, even though if patient has the problem, sphincter problem, 25% of the time, they may have a normal pressures when you check those pressures with manometry. So I'm going to come over there if there are any questions about that.
Okay.
Happy to answer that. Any comments on that, Saad bhai?
I totally agree with you, because
And
end of the day,
Mustafa?
Mustafa, I think, nodded and said, he agrees with you. I think if you're going to do a sphincterotomy, manometry has always been a problem in itself, and the risk of pancreatitis and the fact that you're not always going to be certain about the diagnosis makes it, to me, I have never been impressed by it.
No, I understood, and that's a very valid point.
So that's why something that we never even thought of having here.
Okay. No, I don't think there is a need for that. These do require SOD type 2, require a sphincterotomy. But again, as I said, if you do a manometry and you're able to document that at least you have a definite diagnosis.
Yeah, but you're going to cut anyway. So
You're
it
going to
doesn't
cut
really
anyway.
matter.
So no, yeah.
And that's, anyway, so we just don't bother with it. I mean, we go by clinical diagnosis
Actually,
on this one.
nowadays it's even hard to get a manometry catheter. I don't know, Mustafa, if you know that or not.
Yes. No,
So,
I bet they've probably stopped making
They
them.
start
yeah.
making it.
Yeah,
Yes,
yeah,
absolutely.
yeah.
So we still have the machine. We still here and there do it. But it's for a time being, for a few months, we did not even have catheters available.
Yeah.
And I don't think they are making many. They are making only few. And pretty much more than 90% of the people have stopped doing manometry in the United States.
Yes.
Okay.
Yeah.